I'm Thomas Baldrick at the 2014 ASH Conference. This, of course, the one and only Dr. V from the MD Anderson Cancer Center in Houston, Texas. Thank you for your time, sir.
My pleasure. Nice to be here.
Let's talk about this phase 2 open-label study of Ruxolitinib that you've got data to present here.
Thank you for asking. I think this is an important study. This is a study in patients with Essential Thrombocythemia, or ET, that had uncontrolled disease after failing the standard therapies. Very small study, but it's important to place it in a context of what we are doing these days with patients with myeloproliferative neoplasms in general. As you know, we had a JAK2 inhibitor, Ruxolitinib, approved 3 years ago for patients with intermediate and high-risk myelofibrosis, for which there was no therapy approved ever. Since then, and this was actually very recently, the JAK inhibitor was approved as a second-line therapy for patients with polycythemia vera. That was only about 3 or 4 days ago. This is for patients that don't do well on standard therapy with hydroxyurea, so specifically second line for PV. And of course, the question is, what about the patients with the most benign of these three myeloproliferative neoplasms, ET? Are they patients that do not do well with the standard therapy? Can we help them with the JAK inhibitors? And the answer is yes. There are patients that don't do well on hydroxyurea or anagrelide or interferon. Although the number is very small, the JAK inhibitors does help them. However, it's not as good as the result as one see in polycythemia vera, for example. You know, the mechanism of action of a JAK inhibitor is to inhibit inside the cells, bone marrow cells, superactive or dysregulated intracellular signaling pathway, the JAK-STAT pathway. And it does this very well. That's why in PV, for example, all the cells go down, people feel better, spleen improves, symptoms go away. In ET, it does lower the platelets, but to some extent, it can lower the red blood cell count too. We don't really want that. So, although we have good results in suppressing the counts, they are satisfactory but not outstanding as one would like. The symptoms do improve, the spleen can shrink, but I don't think that we are ready for further development of this drug in ET, having all these other options in everyday practice so far. It's exciting to know activity, but it's still not ready for prime time. Perhaps further studies and development in ET is necessary.
So what do you think as a next step?
Now in ET, it would be interesting, in fact, to pursue that signal. It does work, but it needs to be optimized and see whether one could push it a little bit further and compare, maybe head-to-head comparison randomized studies between Ruxolitinib and standard therapies with hydroxyurea or interferon. But we'll see whether this is going to happen. It's an interesting approach, but on the other hand, this is a very benign condition. The question is, do we need something more, or are we satisfied with what we have? There is a mixed feeling about that.
While I have you, what is your recommendation for treating patients with ET?
The standard first-line therapy appears to be hydroxyurea in many offices around the United States. In some other countries around the globe, that may be interferon, particularly in France or Denmark. In fact, one has a choice between the two, even here in the United States. Hydrea appears to be preferable. Anagrelide is another option. It is officially approved therapy for patients with high platelets that have myeloproliferative neoplasms. So we have options, in fact. Hydrea usually as a first line, anagrelide and interferon, and that's why, in fact, when I spoke about developing another drug, the JAK2 inhibitor, it's hard to see how to position another drug when you already have 3 available medications, and you do cover very well most of the people.
Very good, Dr. V. Thanks for spending time with us. Always a pleasure.
My pleasure. Thank you again.